This content is not a substitute for the professional medical advice, diagnosis, or treatment. Always seek the advice of a physician for any question you may have regarding a medical condition. Hello and namaste. It's me, Aashish Tiwari.
And it's me, Binita Ranabhat.
First of all, I would like to welcome you all to yet another episode of our podcast, brought to you by Creative Callosum Nepal. In this program, we will be discussing various diseases that we have encountered during our clinical postings. Without further delay, let's move on to today's case scenario.
A 67-year-old female presents in our OPD with chief complaints of fever for the last 5 days, cough for 3 days, chest pain and difficulty in breathing for 2 days. The fever was documented to be 102 degrees Fahrenheit, measured from armpit, which was continuous in character and also associated with chills and rigor. Fever subsided after taking paracetamol tablets but reappeared again. The cough was acute on onset and productive in nature. The sputum was yellowish in color, of about half tablespoon in amount, non-foul smelling and not blood-stained. There was no diurnal or postural variation present. It was followed by episodes of wheezing and chest tightness. She also complained of chest pain on the left side after repeated deep breathing and cough. No history of seasonal variation was present. There was no history of orthopnea, paroxysmal nocturnal dyspnea, edema of face and legs. Marked weight loss, epigastric pain, and abdominal discomfort was not present. There was no history of such illness in the past and other major diseases in the family as well. The patient does not smoke, but she cooks food using firewood at her home. She is a diabetic patient and also a hypothyroid, for which she has been taking medication for the past 2 years.
History of fever, cough, chest pain, and difficulty with breathing leads to many possible diagnoses. So, before coming to diagnosis, let's discuss the examination finding of the patient. The patient looked ill, cyanosis and delirium were absent. On general examination, the respiratory rate was found to be 30 breaths per minute. Pulse was 100 beats per minute. Temperature was 102 Fahrenheit measured from armpit, and blood pressure was 90/70 mm of mercury. On examination, upper respiratory tract reveals no abnormality. Use of accessory muscles of respiration was seen, and there was diminished movement on the left side of the chest. On palpation, trachea and apex beat were normal in position. The lungs was typically woody, dull on percussion, and auscultation revealed bronchial breathing and whispering pectoriloquy. There was increased vocal fremitus on the left side of the chest. Associated wheezing was also present.
In your opinion, what may be the various conditions presenting with similar signs and symptoms?
So far, to my knowledge, the probable diagnosis includes pneumonia, pleural effusion, pulmonary infection, or maybe bronchogenic carcinoma and pulmonary tuberculosis. So, ongoing to the depth of various differential diagnoses, no mediastinal shifting to the opposite side and no stony dullness on percussion rules out pleural effusion, as there was no history of smoking, marked weight loss, no history of fever for a long time, no hemoptysis and absence of clubbing and cervical lymphadenopathy on clinical examination. Bronchogenic carcinoma was also ruled out. It cannot be pulmonary infection because there was no evidence of deep vein thrombosis on leg and marked hemoptysis was absent. Similarly, no history of weight loss, anorexia, evening rise of temperature and night sweat rules out pulmonary tuberculosis. So, typical features like high-grade fever, productive cough, chest pain, difficulty in breathing, woody dull note on percussion, normal position of trachea and apex beat, increased vocal fremitus on the left side of the chest, and bronchial breathing and whispering pectoralique on auscultation forwards the diagnosis toward pneumonia. So, what do you think, Binita? Is our case sure of pneumonia?
I totally agree with you. But before coming to the final diagnosis, let's look at the investigation report and confirm our findings so far. On doing routine blood examinations, there was polymorphonuclear leukocytosis. Erythrocyte sedimentation rate ESR was found to be high. Similarly, sputum examination by gram stain and culture revealed colonies of streptococcal pneumonia. Chest X-ray, posterior, anterior, and lateral views showed homogeneous consolidation of lobes of the left lung with ear bronchogram. Now, let's discuss about how the case of pneumonia can be managed.
Management of pneumonia includes general, specific, and symptomatic treatment. General management includes taking rest in the bed and consumption of the nutritional diet, whereas specific management includes antibiotics, which are usually given after sputum examination. If sputum is unobtainable or unhelpful, start with erythromycin 500 mg 4 times a day orally or amoxicillin 500 mg 3 times a day orally. In hospital-acquired pneumonia and pneumonia in immunocompressed host, a third-generation cephalosporin should be started. Symptomatic management includes oxygen inhalation in high concentration to all the hypoxemic patient. Non-productive cough can be suppressed by methadone, fulcodine, etc. Otherwise, expectorants should be encouraged. Intravenous fluid infusion should be done for dehydration and hypotension. Analgesics like paracetamol or NSAID can be given for relief of pleuritic chest pain. In case of respiratory failure, patient must be kept on ventilation.
Is there any vaccine which can prevent this disease?
As there are few vaccines which can prevent this disease and which prevent mortality as well. Pneumococcal vaccine taken once in a lifetime is advised for the patient more than 65 years of age. Influenza vaccine is recommended to those who are at high risk of mortality from pneumonia, but influenza vaccine must be taken every year. Binita, what may be the complication of the pneumonia?
There are some serious complications of pneumonia such as parapneumonic effusion, which is the most common one, empyema, retention of sputum causing lobar collapse, deep vein thrombosis and pulmonary embolism, pneumothorax, acute respiratory distress syndrome, renal failure and multi-organ failure, arrhythmias, ectopic abscess formation, hepatitis, pericarditis, myocarditis, meningoencephalitis, pyrexia due to drug hypersensitivity.
As you have mentioned that parapneumonic effusion is the most common complication of the pneumonia. How to suspect development of effusion with pneumonia? Can you explain?
You have addressed a very good question. Development of effusion with pneumonia is known as synpneumonic pleural effusion. When the effusion appears after the resolution of pneumonia, it is called postpneumonic pleural effusion. Together, they are known as parapneumonic effusion. Persistence of fever, stony dull on percussion, and shifting of mediastinum to the opposite side make the clinician suspicious about the development of pleural effusion. Radiologic obliteration of costophrenic angle in chest X-ray further supports the diagnosis.
In this episode, we discussed the case of pneumonia. Thank you for listening patiently. Don't forget to like, share, comment, and subscribe. We will be back with another episode. Until then, have a good time.